welcome to Karolinska. It's our pleasure to share with you TAVI case here from Karolinska. I'm here, I'm Navzat Saleh, working as interventional cardiologist at Karolinska in Stockholm, Sweden. And with me, my colleague, Andreas Ryck, dealing with both TAVI and mitral and tricuspid intervention. Our case, as you know, is not a live case, which we hope to have, but because of the situation, as you know, we changed it to the live inbox case. This is our conflict of interest for me and Dr. Andreas. And as you see here, the Stockholm or Karolinska is started with TAVI since 2008. And it's the largest TAVI center in Sweden. Last year, we had about almost 400 TAVI cases, and all of the cases was transfemoral cases. Just a few words about our patient today. The patient we have today is 81 years female with severe aortic stenosis and heart failure. As you know, the New York Heart Association's 3B, class 3B, and body mass index 30. She still lives at home with good quality of life. Hypertension, hyperlipidemia, diabetes, and actually it's at moderate chronic obstructive pulmonary disease. She has paroxysmal arterial fibrillation treated with NOAC and mild renal insufficiency. In laboratory data, hemoglobin is slightly low, but it's okay, no any bleeding source. Mild, as I mentioned, mild renal insufficiency and creatinine about 100 and estimated GFR 55. And moderated or severe elevated NT-proBNP, which is indicating that the patient has effect of this aortic stenosis, and she actually came in like a subacute case to be treated with TAVI. This is a picture from the transthoracal echocardiography, and we also see here this very tight stenosis, 5.9 meter per second, and the mean gradient 84. And in this case, actually, it was very hypertrophic ventricle, especially in the septal part. Still good ejection fraction and moderate elevated pulmonary artery systolic pressure. In the coronary angiogram, it was some stenosis proximally in LAD diagonal and treated with Ultimaster, and there was no any other stenosis in the coronary. When we look at the CT TAVI, which is important for this case, especially for the transaxillary, we see that it's a very heavy calcified annulus, and we see the average diameter 22.9 and quite a good distance to the both left and right coronary artery, and the diameter of the sinus SOV is okay. And then see the access, so you see she had treated with a PTA and stent in both right and left iliac artery. We see the both arteries are not appropriate to do TAVI transfemorally. That's why we look at the subclavian artery, the left one. We see there is some plaque on the just at the bifurcation to aorta. You see there is some plaque and stenosis on the left side, and the right side was much better. That's why we decided us to do the after the heart team evaluation to do the right transaxillary TAVI. And our procedure plan to do the case is in local anesthesia with mild sedation, and have a radial puncture, radial artery puncture from the right side, 6 French sheath, and long wire from the radial, and then with snare externalized from the right femoral artery. And we put in the pigtail for the procedure, also from the right side. For this procedure, because we do the TAVI from the right, so we put in the temporary pacing for the left jugular. We usually use permanent pace wire and connect it to the permanent pace generator, because we have been showing that this is the less risk for dislocation, and actually very low risk for tamponade with this procedure, with this technique. And then, as I mentioned, transaxillary access with micropuncture, ultrasound guided. And for the sheath, we usually actually use the iSleeve expandable sheath 14 French, playing for a pre-dilatation with true balloon 21 millimeters. And so I'm going to show that we used 22 balloon for post-dilatation. We used the Medtronic Evolute R 26 millimeters in this case, because usually it's the one which is more proved for that transaxillary access. And the closure device which used in this case is a Manta, and use a PTA balloon Metacross 7 millimeters at the puncture side before closure, as we are going to show you the case. I think it's just a picture to how this is for the left actually, but in our case it's from the right. Is showing how we are thinking, just putting the wire, long safety wire from the right, from radial artery, and take it out and snare it from the femoral, and put in the pigtail from the femoral.
We will come back to the point of having the safety wire is that you can always then have a balloon, and you can actually simultaneously deliver a stent from the femoral axis and have a balloon from the radial axis on the same wire. So with this technique, you will be able to stop any kind of bleeding you might have after you take out your sheath.
Okay, I think we can go to the film, to the case, and then go back to the discussion and questions after the case. Please, Andreas, you can just continue.
This is a 17-minute long film, which will start now. It's edited, of course, and you will see in the lower right side, you will see a room camera. And here we have already, at this time point, we have the wire from the radial coming up, and we're meeting with a snare from the right femoral. And then we usually actually use a 0018 wire, which is slightly thinner wire than we usually have for a normal access. And with that method, you can have the wire out through the femoral sheath, and still besides it have a pigtail without having a lot of oozing. So we see it's coming down soon to the femoral. Is it playing? Yes. So now you will see, just drag it down and take it out, and with this 0018 diameter wire, it's very easy to take it out through the sheath also in the femoral. And then we have both ends of the wire out. This wire is also 300 centimeters, so we will have a decent amount of wire on both ends. That's in one femoral and in the radial. Now we're going over to the puncture, and you see on the upper side, you see we try to do the puncture in almost exactly the same way as in the femoral, that is with ultrasound and with micropuncture. And it's actually surprisingly similar how it looks also on the ultrasound screen. So we see it in the top. Then now we will see the wire coming out from the needle soon. So here is now the small wire that you get first with the micropuncture kit. And then when that goes in, we do the same steps that we use for micropuncture for the femoral, that is to go in with the small 4 French catheter that comes with a micropuncture kit, upsized then to 0035 wire, and then to a stiffer wire after that. So we'll see that coming here. This is actually something, before we started this percutaneous access for transaxillary, we were afraid we would, in some patients, maybe not see the subclavian or axillary artery, but it's in our experience, even in patients with severe COPD, we've always been able to see it well on ultrasound with the puncture. Now we're coming down soon with the sheath. Here you see we have exchanged to a stiff wire. Of course, there is sometimes a problem that you don't want the sheath to go, dilator is quite long on this sheath, so you see it's almost touching the aortic valve.
Yeah.
So you need to go back a little with the dilator to get the last part of the sheath in, and you shouldn't have the sheath too far in, because then you need some distance for the valve also.
Yeah, I think Andreas, one question can be here. That's why we don't, because as you know, the Medtronic valve you can put in with sheathless, but because we are using the Manta, and the depth of the artery is very important. That's why we put in the sheath like this one, the eye sleeve, which is expandable. So to avoid to change to take out the sheath during the procedure.
Yeah, I agree also, and especially in cases where you pre-dilate, post-dilate. If you go sheathless with the valve, then you will have, it's a bit difficult to compress manually while you exchange sheaths in the axillary position, so that will cause some bleeding then. It's just the crossing of the valve, and then we put down a safari wire. So from the right axillary, one other challenge is, of course, that the angles are a bit different. So you're coming a little bit to the inner side of the aorta when you go down with the device. You will see that soon when the device is coming down. So then if your heart is completely horizontal, that will be a challenge to get the device placed, the stent, the valve placed in the right fashion, actually. So that has to be measured on the CT. Here, the heart was not horizontal, not vertical either, but something in between. So acceptable, at least for Medtronic.
I think it's about 45 degrees. You can say that it's more than 30 degrees from the right is going to be a little bit issue, but here it was 45. One more thing is when the way I think it's some other centers uses like that. We use usually IM catheter to directly to pass the valve, to cross the valve, and then put in the safari wire just directly, not changing to pigtail.
Now we have put in the pigtail from the femoral, and that you can do and still have the safety wire out through the same sheath. And now we are soon ready then to take the valve.
The pre-dilatation balloon.
Yeah, sorry, the pre-dilatation balloon first, which was a 21 in this case, and it's a true balloon, which I think is quite common to use for lots of centers. Now the balloon is positioned. You will see the balloon markers, and soon you will see the pacing. The pacing is at our center almost always done over the wire in the ventricle. So you might see here that we have connected one connector to the wire, so the stiff wire which the balloon is on. And now you saw the pacing there and the balloon inflation, quite short. Was it done already? Oh, that was maybe... Yeah, it was done. Yes. Now it's balloon retrieval. And now it's the system in. As you might know, the Medtronic Evolute is rather stiff, and it's some kind of a curve to come down here from the right axillary. So there's also maybe an argument to actually have a sheath, because if we have the idea, if you don't have a sheath here and you pull a lot on it and go sheathless, you might induce a dissection in the axillary artery. And you see here it travels down quite nicely, and you see there's just enough room to the sheath, and at this position quite often you need to retract the sheath a little bit to have room for the valve to be released and later. Also see that the projection seems to be quite straight on the valve system. You see that there seems to be not much parallax. So then the next step is then to check the position and do the gradual release of the Evolute, and we quite often from the right axillary you will see the aorta you see we come from the minor curve of the aorta because we come from the right axillary, and that means that the valve is a little bit canted. It's at an angle to the aorta, which means that we will have it in a higher position, usually on the non-coronary side. So the idea is then to try to implant it really high on the non-coronary side to avoid to be too low on the left coronary side of the annulus. I see we're slowly taking, unsheathing the valve. Trying to keep it high as possible.
And I think it's in this this step, maybe you need to have some fast pacing. I think we had 110. I didn't see it. But
yeah, probably from this step on. Usually you induce some 110, 120 pacing while opening the valve. I'm not sure actually if it happens here. Yes, we are connecting it now, it seems.
Yeah.
Let's see.
And
so you're pacing through the wire, is that correct?
120.
You're pacing through the
Sorry,
through
we didn't hear you, Dr. Habib.
Yes.
Yeah, now we hear you. What's
the question is, are you pacing through the LV wire or?
Yes,
or
it's LV wire.
You have a pacing wire too.
Yes.
Yeah, even if we have in all.
We use the other wire is for bradycardia pacing, anti-bradycardia pacing only. So we actually have two separate systems. So we have the other one set at 40 or 45, just in case of bradycardia on demand pacing.
Actually, in most of the cases, for Medtronic, we know that the pacemaker rate is higher. That's why we put in the pacemaker. But in the other case, for the SAPIEN or for the accurate cases, most of the cases we do rapid. If there is no any conduction problem, so we do the rapid pacing on the wire.
Yes.
And we have, I should say, almost 100% success. Some of the wire, maybe if you have even with the Safari, with the other wires, is function, but sometimes you need to scratch the wire to get it better.
Yes, so most of our patients, which we treat with TAVI, they don't get this wire, the dedicated temporary wire to the right ventricle. They only have the wire for the fast pacing.
How often you do the cusp overlap with the Medtronic?
It's a good question. My personal view is that it's probably the best view if you want to implant high. I'm not sure. I didn't check the reconstructions for this one. It seems to be quite straight on AP, but that's actually sometimes the cusp overlap is not far from AP.
Yes.
I think it's a good idea to use that, especially if you want to implant high.
Absolutely.
So we see here the implantation depth. We saw some contrast coming. It's like 4 or 5 millimeters. So, but it seems like on the left coronary side to be deeper, like we predicted. So we have the idea that we try to get it probably, it can be discussed, but it seems a little low on the left coronary side, and there is still space to go up on the non-coronary side. And since it's easy to resheath it, recapture, that's, I think, what we did in this case. Actually,
that time I had not so much press on the valve. I just try to keep it neutral, but the position I think is still good.
Do you use another incidence before the final loading, even in this cusp overlap technique?
What was the question again? Sorry.
Do you use another incidence just before the final loading of the valve in this cusp overlap technique?
Another projection.
Another projection.
In my mind, if you're sure about the projection, you can stay in the same projection. But of course, for other valves, say you use an Edwards where you want to see it travel, or even a Medtronic from the femoral side, you want to see it nicely traveling across the arch. Then you go LAO first to see that, and then you switch to the cusp overlap when you start implanting it.
The typical projection we are using nowadays, it's RAO Codo.
Yes, that's the most common for this. But it depends on the rotation of the heart, so it's different from
especially with the transfemoral. It's very nice.
Yes.
But as you mentioned here, I think basing is mandatory, especially with this heavy calcification. We suffered a lot, we learn from those patients. But I think we are lucky now with this retrievable recapture type of Medtronic, the new valves.
Yes, sure. So you see, we already did a partial recapture here.
Yes.
And pull it up and release again. It seems to travel up a little bit on the non-coronary side. Take a new shot. It's a bit like a live case to me too, because I don't completely remember all the steps we did. So, but it seems to have gone up a little bit, not too much actually. The limitation when you come from the right transaxillary is when you pull up against the minor curve of the aorta. So it's a bit difficult to get it completely parallel. You would ideally want it to travel up on the left coronary side instead, but that's for geometric reasons difficult to achieve. So you need to go, basically you need to aim for a 0 position on the non-coronary side, and then you will end up as high as you can on the other side. And you see there is still some signs of leak, and it's still maybe a little room to go up. I think we took it up once more, but I'm not sure, so we will see.
I don't think so, because we decided, I think we can see there. Of course, it's from the other side, it's too low, but because if you take it up a little bit more on the non-coronary side, maybe it's
we can hear the panel. How many would at this point say it's good enough and just leave it, or how many would take it up a little more?
Dr. Andreas and Dr. Nowzad, I just would like to introduce the panel.
Yes.
Dr. Mohammed Belghith, he is from Saudi Arabia, from Riyadh. TAVI technique in the Middle East and beyond. Dr. Dhakr Lahidab and Dr. Nadam Hajlawi, they are sitting next to each other, and they are from military hospital in Tunis, and they are both of them experts in TAVI in Tunisia. So
perfect.
Any comments, Dr. Andreas' question?
Yes. Yes, so we can continue playing the video and we'll see what happens. In my mind, there is still room to go up a little bit, not much. There's just like 3 millimeters up. So it's really, what's good with the axillary axis is that you have more of a one-to-one response when you go up and down with the system. So that's actually not too bad. What we should comment on also is maybe the setup. You can do it differently in transaxillary. We try to make it as close to a femoral as possible, which means there will be some parts of the sheath sticking out outside the axis here through the skin. We take that part and bend it down towards the femoral side, so we can actually have both operators standing in the normal femoral position, and we go down. We have the delivery system that way too. I know some other centers have it sticking out more directly to the side of the patients, but we think that's more difficult with the maneuvering. So
it's much better. Yeah.
In this way, we can have it, resting on the patient, etc. So you have a better feeling of going in and out. Also, and potentially you can suture the sheath in a slightly bent position to the skin too. Let's see what's going on. We're going back to the handle.
I think you decided to maybe.
It looks actually slightly higher already.
Yeah, and then remember, this is for 1 month ago, and forget it what we do. But we have many cases. But I think we decided to, because we see a little bit more. It's higher on the non-coronary side. It's about 2 millimeters now. So it's we going to go
pigtail is out,
release.
so now comes the full release, which is done under some fast pacing too, as you see, like Medtronic recommends. Then we see it release fully in just a few seconds here. Usually it tilts a little bit, then it of course follows the shape of the aorta.
Yeah, this is usually with the Medtronic, and still is catching the delivery system, catching the valve.
Yeah, it's not complete. Now it seems to be free. And now, of course, from this axis, since the wire is forced, since it comes from the right side, it goes a little bit, not completely straight through.
And we decided to do post-dilatation as I mentioned, 22 balloon.
You will also notice here that what happened is that it went down a little on the non-coronary side and stayed at the same place on the left side. So there is some leak. There is echo too, but I don't think it's recorded. So what we decided for is to try to optimize this with a balloon. So this is a 22 balloon, and you might remember it's a 22.9 annulus. You could potentially even go up to 23, but then you have some risk maybe of injuring the annulus.
Especially it was very heavy calcified.
Yes,
in
this
this
heavy
case,
calcification, you would be a little bit afraid. And you see it's actually straighten out the valve, so it does something to the valve with this dilatation. This is also pacing on the wire.
What kind of balloon you use?
True balloon again, 22 this time.
But the semi-compliant balloon,
it's non-compliant.
Non-compliant, yeah.
So it's very exact on the size. You get it to exactly 22 when you inflate it. Repeat autogram. Better, maybe not perfect, but the wire is still in too. I think we will see the wire retrieval soon. Yes, wire is out. And now the question is then the access handling, how to take out the sheath and do the closure of the axillary artery on the right side, where we have our system for that, which seems to work quite nicely.
Exactly. We try to take back. We usually do it with the dilator, the eye sleeve, and we have the safety wire, as we mentioned, outside from the femoral. And
at this time point, you can already put just as a precaution, put in a decent normal-sized PTA balloon, 6-7 millimeters, the same size as the vessel or slightly larger. From the radial access, they go easily through a 6 French.
Actually, we prepared it already at the beginning of the procedure, and you're going to see that here is the balloon.
So this is the balloon, and now you see that this is actually the image. This means the manta is already deployed here. So this metal marker sits on top of the collagen, which is pushed down by the manta. So it's an angusil-like mechanism.
Yeah.
What we don't see is that there is a kind of a part inside the artery, which is like an anchor, which is pulled onto the vessel wall.
Yeah,
that part is not radiopaque. So this means the manta is deployed. So at this point, you should have hemostasis. We think it aids to actually add a routine balloon inflation from the inside just to make the sealing better, especially since at this place anatomically it's hard to compress or have manual compression from the outside, which you usually have in the femoral otherwise for a few minutes. So we go with a soft 2, maybe maximum 4 atmospheres inflation of the balloon. And just to allow it to coagulate more at the puncture point to avoid any bleeding. And then after that, we do the final assessment.
Through the catheter from the femoral.
Yes, you will see it coming up. So we usually, since we have a wire up already, it's very easy to just push up it. And we usually take a guiding catheter up and place it close, deflate the balloon, inject. If everything's fine, that's good. If not, you reinflate the balloon and you take out your guiding catheter and go up with a covered stent if needed, which is also easy since you will never, with this technique, you will never lose the access. Even if you have a dissection, you can cover that with a stent too. You always have the wire through from both ends, actually.
You see now the guiding
catheter is positioned. And I hope we'll deflate the balloon soon. Now it's coming. And you see this metal marker that's actually that remains in the body of the patient. That's at the collagen of the manta. Deflate and take back balloon. And it's also kind of nice because then you always know where the puncture point was. It's always very close to this metal marker. Now you see the selective injection of contrast soon, I hope. Now. And you see there is almost no leak at all there. So it's actually a nice result, and it would be hard to tell from the appearance of the vessel that we had actually done the procedure. There, no dissection, nothing else. But we must mention that it happens from time to time that the manta in this position, in the axillary position, works a little bit less well than in the femoral. So you should have a covered stent somewhere in the vicinity if you have a problem.
Actually, you can you can see if you see the stainless suture or the metal from the manta is very near to the vessel. You know that is the manta is successfully implanted. Sometimes when you see it is very far from the vessel, so you can suspect that maybe you need to suture or do anything, something with the vessels.
Which size of manta this one?
It's
Small?
18 French. Since we have a sheath in, which after expansion is actually 18 French.
Yeah. Now we'll finish with the case. So open for the discussion. If you have any comments or questions, with pleasure to hear it about.
My question is about the paravalvular leak. Do you check it by the diastolic pressure or echocardiography of the cath lab, or only by fluoro?
Usually we do it with the echo. Unfortunately, they did not register this one. Usually we have it, and with the contrast, as you saw, we sometimes if there is discrepancy between them or it's not sure, so we do it with the to measuring the AR index with the catheter. So of course we look at the diastolic blood pressure, but if you need to be more exact, you need to change it with the pigtail and just checking the AR index. But I think it's if you have two methods with the echo and the aortography, if you have a good pictures, so good results, so you can be satisfied.
Yes, there was some leak actually in the end of the procedure. It was graded as mild on echo. The echo is on another machine. That's why it's not on this composite image. We could, of course, discuss if we should have used a Pro instead of a R Evolute, which has a bit more sealing capacity. We were a bit afraid with the size of the vessel, because then you add two more French, which is maybe not enough, a lot, but with this patient, it was already a bit borderline with getting the sheath in. So we thought we were more safely doing the procedure with using the Evolute R instead of Pro. But of course, can be discussed.
Okay. Please, I have two practical questions.
Yes.
The first question, when the femoral artery is not useful for many reasons, do you think when we have to go by subclavian route, is it better to go by the left because we have less angulation?
Yes.
That's the first question. The second question, if it was an Edwards valve, so a balloon expandable TAVI, do you rely on left ventricular rapid pacing? I did it with Sapien 3, but I have always the fear that it will fail to capture the ventricle, and the consequences can be not good when it's a Sapien 3 valve.
Yes, first question, left subclavian is always the preference. Since the angulation is much better, then you will travel on the outer curve of the aorta. You don't have this issue with the valve coming in a different angle than the patient's aorta. In this case, since there was a stenosis, we didn't do it, but 90% of our axillary or subclavian cases are from the left side. That's correct. So that's always preferable if possible. Second question with LV pacing. In our experience with our setup, we with more than 100 Edwards valves with LV pacing never had an issue with it. What we do with Edwards is that we do a test pacing without inflating the balloon, nothing for 5-10 seconds, and see that it works perfectly. What we also do is that the part of the wire where we attach the clamp just distal to the delivery system, we actually scratch off. There is a kind of a coating, plastic coating on all the stick parts. We scrape that off with a knife to make sure. And so far we have no issues. And actually, even with the RV pacing, I mean, these pacers sometimes move around a little bit, and you don't actually look at them so much because you actually look more onto your balloon. So if your left ventricular wire will move, you will for sure notice it because that's just where you will be looking. So with our setup, we had no problems, even with Edwards, I must say.
I would like to welcome Horst Sievert and Alain Cribier, who just joined us. So Horst and Alain, any comments, any question?
Maybe I'm not sure whether you already discussed this MANTA compared to ProGlide in the subclavian?
Not yet, not yet. There is not too many publications. We have one small publication from our center, which is not too favorable with the MANTA, with almost 50% failure rate, although all patients could be safely treated with a covered stent with no other complications. Then there is another bigger publication from Hamburg, which actually showed a much better success rate. So our most recent experience is that all the most recent cases here were successful with the MANTA. But now we have added a routine low pressure balloon inflation of the puncture site from the inside. We think that from the femoral, usually you put a closure device and you put your fingers on for a couple of minutes just to make sure. But if you put your fingers on here, it doesn't help that much. So maybe it's the best way.
Do you think that the MANTA in that location is better than ProGlide?
Probably, but I'm not sure.
I think sometime when I don't know, we used ProGlide before, but not for the subclavian. But I think when we have to change the catheters betweens, maybe we get some hematoma, especially if we looked at our cases, we had failure with MANTA. Usually when we did it with sheathless, this time it's going to be hematoma, and the depth of from the skin to the vessels become different, and you don't get the all the way the collagen and the suture down to the vessels. I think it's one of the reasons. But the answer for your question, we have not using ProGlide for the subclavian, so we don't know if with the comparison between these two. Do you have any experience of the ProGlide from the subclavian?
You've used a couple, and the results have been kind of mixed. I would say about 80% success rate, and the rest had to be solved by either prolonged balloon inflation or by covered stent. So it's well, not overwhelming. But as I understood, the results with MANTA are also not overwhelming, right?
Yes, but the good thing with the MANTA, if it works instantly. So that's a good thing. You don't have oozing for a couple of minutes, which you might have with some other systems. So it's kind of an instant hemostasis if it happens. And I think now with what should we call it, some balloon inflation assisted MANTA, then it seems to work very well in our hands now. Although we must say that we are now quite aggressive with the femoral access, which means very few patients nowadays go for a transaxillary access at our site. So we balloon quite often in the iliac arteries to get the sheath up there. In this patient, the limitation was the size of the stents, which were nitinol stents, which couldn't be expanded enough in size to accommodate the sheath. So it wasn't possible.
So what percentage of your patients do you need an alternative access compared to femoral?
1%.
Oh, yeah. Okay.
Any experience with the trans cable in such case?
We were interested a couple of years ago, but now with such a high success rate with the transfemoral, including shockwave if needed or regular PTA balloon if needed, and actually we think that niche is so small we haven't done it.
We did few cases like with the shockwave and even non-compliant balloon to dilate the femoral and the iliac arteries.
Yes, we've done that lots of times.
Question about stroke prevention in TAVI implantation. Do you use the Sentinel device, and what's your experience with this device? Do you think access from axillary access or subclavian is more? There's more risk of stroke with these patients.
Yes, the risk is in studies higher for stroke, although if you use the transaxillary access, it will be difficult or impossible. From right side, it's of course impossible to have a sentinel used, since it also comes from the right radial. So then it's going to be hard to prevent the stroke, but it seems to be slightly higher for these patients. Of course, the discussion will be all these patients also have a higher calcium load. They are more sick in other aspects too. They have lung disease, they have more kidney disease, etc. So it might be a bit hard to differentiate if it's access or the patient.
All right. Okay. Thank you very much, Nawzed and Andrea.
Thank you.
Habib,
Yes.
good morning. If I can question yes, hi. For the operators about the timing of PCI, you do the PCI usually before the TAVI, or it depends on the type of coronary disease?
It's in this case because it was a proximal stenosis in LAD, so we did it and because of two reasons. One, because it was in the proximal part, and we know that with the Medtronic too much metal, and then because the patient came admitted with a heart failure and actually not so much chest pain. So we didn't know if we can just stabilize here just to do PCI, but even after PCI, she continued to have to had heart failure. That's why we did the PCI before, just to try to stabilize here, and because it was so proximal in the LAD.
But 90% of the PCIs are done in a separate setting before. So to do it in the same setting, it's of course possible, but it's not too routine.
All right. Thank you so much, Nawzed and Andrea, for this very elegant presentation and full of messages. Thank you, and you have to move the program now.
Thank you very much. Have a nice
I have the honor of introducing Professor Alain Cribier. Alain is my mentor, my friend, and is a strong support and co-director for Pafcic for many years. So Alain, welcome. I think we have already a recorded lecture, so we're going to listen to Alain, and then he will be with us for the question. So can you have Professor Cribier lecture, please?
Dr. Bonifarat, dear Habib and Holt, dear colleagues and friends from Tunisia and from Africa in general, it's a renewed pleasure for me to attend this meeting and to give this keynote lecture. I think I didn't miss one Pafcic meeting for the last 2 decades, probably. And unfortunately, I was unable today for health reasons to be with you live, and so I have recorded this lecture. Thank you for asking me to talk about the state of the art in TAVI. And can I have the first slide, please? So this is a title that I have slightly changed. Where are we with TAVI, and are there still unresolved issues? So this is briefly my disclosure. The 16th of April 2002, as you know, our team in Rouen moved from dream to reality while doing the first TAVI case after 10 years of research and against the opinion of all experts. We could demonstrate in a single patient that TAVI was feasible with no operative complications and excellent hemodynamic result. We are today reaching 18 years of experience of TAVI, and an incredible number of nearly 1 million TAVI cases have been performed in the world in about 70 countries with 2 great devices, the Edwards balloon expandable valve, the one that we developed, and the self-expanding Medtronic valve. The growth of the procedures is expected to reach 40% per year, which is just unbelievable. The success of TAVI can be explained by, on one hand, I would say the improved techniques and skill with better patient screening, in which the industry played a major role, increased experience of the teams, a constant improvement of the devices, valve delivery system and associated hardware, facilitating the procedure, and on the other hand, by the amount of scientific evidences. It started by a number of very convincing national and international registry in high-risk patients first, such as the Source or Advanced Registry in Europe, for instance, and later by registries and match registries in intermediate risk patients, showing the non-inferiority of TAVI versus surgery. But the key data, the apotheosis of TAVI came from the randomized trials with the Edwards and Core valve in high risk, then in intermediate risk patients, and more recently on low risk patients, demonstrating again the non-inferiority and even the superiority of TAVI versus surgery, notably concerning the mortality and stroke at up to 2 years. In 2019, the final surgical risk category approved by FDA was thus low-risk patients, making TAVI a valuable alternative to surgical valve replacement, whatever the surgical risk. Over time, the TAVI valves and delivery systems were markedly improved with multiple valve sizes and decreased sheath sizes, markedly improving the safety and results of TAVI, but you know that very well. An important procedural progress came with the minimalist transfemoral approach that we developed in Rouen. We have been pioneering this approach after the launch of the SAPIEN XT valve. The minimalist approach, enhanced with the SAPIEN 3 valve, has made the transfemoral approach a short, I would say, stent-like procedure, which can be now performed in more than 90% of the cases with local anesthesia, short hospitalization stay, and return home in 70% of the cases before day 3. This procedure is also cost-effective. The minimalist approach, initially very criticized by the US physicians, is now performed in 80% of the cases out of 94% of transfemoral approach. Alternative accessors in the United States being used in only 3% of the cases. In the course of the last 18 years, a far work of new devices have been investigated for TAVI, but many of these devices disappeared. However, some of these devices are still used in Europe. Besides the two leading devices, the balloon expandable Edwards and the self-expanding Core valve, clinical experience has been obtained with the Accurate, the Portico, and the Lotisage devices. Actually, the Lotisage has been recently removed from the market, and the Accurate and Portico failed to demonstrate their non-inferiority on randomized trials compared with the leading devices so far. Newer promising devices are being currently investigated. The self-expanding venous valve has been recently approved in China. We don't know too much about it, but it would decrease the pacemaker rate and would be very efficient in bicuspid valves. We don't know more than that. Actually, we know more about the MyValve from Merrill. This Indian device is the only competitive balloon expandable valve available and is CE-marked. The experience is increasing with several hundreds of patients treated in Asia and Europe. Its characteristics are quite interesting, with a unique 14 French introducer for multiple size matrix with a number of half sizes and also the largest size available. It allows most accurate positioning and lead to dramatic drop in pacemaker and perivalvular leak rate. A randomized trial versus Core valve and Edwards is ongoing. We are looking forward to the results, but I personally guess that this device, which would be also cost-effective, may have a bright future. We'll see that later. So what are the remaining questions and issues with TAVI in 2020? How to select the right valve? The safety issue comes first. The selection will take into account the annule size, the access to the aortic valve, the coronary location with the risk of occlusion, the best hemodynamics, the risk of percutaneous paravalvular leak, the risk of pacemaker, the risk of prosthesis mismatch, and the reaccess to coronary arteries. So all of these elements will be screened by CT scan, and which is the predominant tool for selecting the patient for this technology and for selecting the valve. But it also depends on the experience and preferences of the team. And there is something else, the sale price of the prosthesis, but we will see that later. So, using predominantly the femoral approach, vascular complications are a concern. Actually, with the advanced technologies, all introducer sheaths are more or less equivalent in size, suppleness, and conformability. The prediction of complications results of optimal CT scan evaluation as per calcifications, tortuosity, and diameter. The ratio vessel internal diameter over sheath diameter is recommended to stay below 1.05. Online imaging by angio and or ultrasound is clearly helpful for a more accurate femoral puncture. Some particular cases, for example, the horizontal aorta and vertical aortic annulus. In such a situation, there is no doubt that the balloon expandable device is preferred because of the steerable commander delivery system. Another particular case, the dilated ascending aorta, which is also more frequently associated with bicuspid valve. The balloon expandable valve offers an intra-annulus anchoring and is certainly preferred in this situation. At the opposite, for an optimal coverage of very large annulus, one should prefer the self-expanding valve, such as today the Evolute Pro, for example, which offers broader range of size up to the largest 720 square centimeter annulus area. The new MyVal would offer a competitive balloon expandable system covering up to 804 square millimeter with its larger size of 32 millimeter. In the particular case of small annulus, increasing the risk of prosthesis patient mismatch associated with higher mortality at 1 year, the self-expanding valve with its supraannulus anchoring is certainly the best choice. The risk of mismatch increases in various settings, well studied in the STS American registry, as shown here, including female patients, annulus below 23 millimeter, and valve-in-valve cases. It is now very well demonstrated that in valve-in-valve cases, for example, when the internal diameter is 21 millimeter or below, the preferred choice is definitely the self-expanding, which offers a smaller gradient and higher valve area, whereas in larger diameters, any model of valves can be used. What about the risk of coronary occlusion? You can see here the different factors impacting the coronary access. They are all very well known. In low coronary insertions below 10 millimeter, for example, and in case of fairly straight sinus, there is no questions about using preferentially the balloon expandable valve, which offers easier coronary protection and easier coronary access acutely and on long term. In this regard, the Sapien 3 and the MyVal, with their large upper cells, are particularly adapted. This is also a clear-cut advantage after valve-in-valve if reaccessing coronary arteries is needed. Besides this, the rate of delayed coronary obstruction after TAVI has been certainly low, but 3 times higher after self-expanding compared to balloon expandable valve. So balloon expandable preferred in these cases. Concerning the issue of annulus disruption, this is a very rare but catastrophic event, more frequent in case of severely calcified annulus and subvalvular calcifications. In this setting, the self-expanding valve has clearly to be selected. In this setting, overexpansion of a balloon expandable valve should be absolutely avoided. Concerning PVL, it is a regular observation that the degree of PVL is less with the balloon expandable valve than with the self-expanding, and this has been once more demonstrated in the last randomized trial in low-risk patients as shown on this slide. The same conclusion about the superiority of the SAPIEN 3 over the Accurate in the SCOPE-1 trial. Concerning the risk of complete heart block and need for a new pacemaker, it is a current observation that this risk is much lower with the balloon expandable than with the self-expanding valve. The compared results in recent series are shown on this slide, and as you see, this is an important issue when we have more and more to deal with a younger population. This is a summary of the respective advantages of the balloon expandable versus the self-expandable valve that I have described. The SAPIEN 3, for it, you know, the easiness of use, positioning and delivery is much faster, easy access to native valve in challenging anatomy, best coronary reaccess, low rate of pacemaker, low rate of PVL. And in favor of the self-expanding, you know, the fact that it's a repositionable valve, less traumatic, with, however, more PVL and pacemaker, but best hemodynamics in small annulus and valve-in-valve cases, and broader spectrum of size. So the final question is about the indication of TAVI as a standard strategy in all patients, whatever the surgical risk. I guess that if you ask a patient, his preference will always be not to be operated on. They have all heard about TAVI today and as an alternative to heavy surgery, and they are claiming for it. But as physicians, we have to be reasonable, and several issues have to be considered on case basis and shared with the patients. One of the main issues is the uncertainty concerning the long-term durability of TAVI valves, even though there is no alarm on durability beyond 5 years so far. Furthermore, infraclinic early valve thrombosis have been recently pointed out, and it is a phenomenon being currently investigated by CT scan that could lead to further changes in the anti-thrombic strategy, but it does not seem to me to be a very serious worrying event so far. My last slide will be about the issue of cost of TAVI, which is a strong limitation in many countries in the world. The cost has been significantly decreasing by 24% in 4 years with advanced technology and world expansion of the procedure. However, the acquisition price of the prosthesis is a main issue since it varies considerably from one country to another and depends a lot of the model of valve. This makes the price of the valve the determinant factor for selecting a prosthesis, overpassing its potential clinical advantages. Well, this is where we are. I thank you very much for your attention, and I wish you a great meeting. Thank you again for your invitation.
And we're really glad to have you. I think you're on a mute. You have to unmute yourself.
Do you hear me?
Yes, we hear you now.
Hello, I'm sorry. Well, you understood that unfortunately I was not sure of being on time here for this session because I have on myself an MRI, you know, so I am just out of a dobutamine test on MRI and everything's fine. So I'm glad to tell you.
Oh, great.
And so my heart is okay. Well, actually, I came late and I am ready to answer and to discuss with you if you have any questions about this presentation that I did very quickly yesterday. So,
thank you so much.
I have seen the end of this beautiful case done from the subclavian artery from Sweden, and it was really beautiful. Congratulations for this case. It was very interesting.
Thank you very much.
Excellent. Any questions to Professor Kribi? We don't have much time, actually.
I have a question, Habib.
Yes, go ahead.
Hello.
Hi, Professor Allen. How are you?
I am well. I am fine. Just say I am fine.
You will be fine because we are with you.
Thank you so much.
The question I have, it's the same question. It's cooking everywhere. It's the age.
Yeah.
65 or below 65. What do you think?
Well, actually, I'm supposed to be reasonable. When I am discussing with the patient and when they are less than 65, I am not pushing them to have TAVI now. So I am, I explained the for and contra of these two techniques, TAVI and surgery. I discussed with them, and finally they made their own choice. But they have to be absolutely aware that we are not ready to accept the idea that the valve could be inserted percutaneously 3 or 4 times, in the patient's life. And also, personally, I don't know whether the surgeons are really able to remove a valve after 10 years, for example. So this is something that I don't know. I don't want to replace valve replacement by a Bantal procedures, for example. So I explained to the patient the risk of dysfunction of the valve after 5, 6, 7 years. We don't know yet. And so below 65, I am more or less pushing them to accept surgery.
Alain, I think we arrived to the end of the session, but I have an important question to ask you before we close. This is an African meeting, and as you know, TAVI is not really taking off the way we wish in Africa, mostly because of the cost. You have shown us that actually the cost has substantially decreased, but 40,000 euros for one prosthesis is already expensive for the African continent. So my question to you, you have shown us the venous prosthesis from China, the MyValve from India, and I think there is also an other South African valve that has been cooking for many years. We don't see it yet. Do you think this would, and maybe actually the venous valve has been used by a Horst. I hope he's still with us, and he was proctoring
which valve? I'm sorry.
Asia about it. So, do you think this will solve the issue of cost, or you think
yes, this is a part of the issue? I am really discussing with Meryl, for example, with MyValve. It should be cost effective, and so this could be interesting for developing countries and for Africa in general. I think that the cost is the main factor. And so, more or less, the valves give the same similar good result for the patient, and the venous is okay. China's valve, South African valve, I have absolutely no experience, so I cannot say that they are better or less good than the other. But the cost is a number one issue, and it should be decreased by 50%. This is what we would like to see. To offer this opportunity of being treated well in Africa and in many other countries. With TAVI.
All right, Horst. Before you close, do you have any information about this? Do you think the venous valve will be offered at an affordable price for the limited resources countries, or not the case?
Well, my impression is unfortunately that the newcomers like MyValve and Venus are not selling much cheaper than the others. So they try to be in the business. But I mean, the more valves we have, the more competition we will see. And this will bring the price down for all companies.
Yeah, sure. Multiplication.
Okay, thanks so much. That was a very, very interesting session, memorable. We have to close because we have to go to Johannesburg now with Farley League, and it's a live transmission from Johannesburg. Thank you so much, and please stay with us. I mean, you have to just to join the platform and stay. Thank you very much.
Thank you, Evan.
Thank you for joining.